But congratulations. Evidence-based research. I would have loved to participate by my physical. I wish to illustrate evidence-based research in Ayush using yoga in psychiatric conditions. In the last 2-3 decades, under the guidance of several able leaders, Dr. Nagendra ji, to mention a few. So what I will, how to build evidence in Ayush approaches and illustrate this with examples from its application in psychiatric. Has exponentially grown in the last decade. Here, the PubMed listed 641 or even more, because the average per year in the last 5 years was a huge number. 640 odd publications were listed in the PubMed. Yoga, some overlap between yoga and yoga therapy, though in PubMed listing yoga listing though. What is striking is that the numbers stagnant in the last 5 years in yoga therapy, and this is where we need to build more based research. And why, what is yoga? I don't have to tell the Ayush group what yoga is. We have to practice, and it is very relevant to mental health, because ever since it was mentioned, DC manah prashamanopayaha iti yoga, to yoga Patanjali is what we are using the sutras to guide us in developing yoga to its fullest extent. There are, of course, several limitations which have been cited by many reviewers who have talked about yoga in yoga research in particular. There have been large numbers of studies which are just cross-sectional, and many just pre-post used in a comparative arm in their research, comparing another intervention with yoga. But randomization has been very poor, and even if it is randomized, the comparative listed exercise or treatment as usual translate into clinical practice. And in clinical research has been building evidence. We of course draw data from case reports or case series, single group studies, comparative studies. As we keep moving up in this slide, of course, we also would add multi-center trials. The evidence gets even stronger, confirming role for a given intervention is even stronger. And of course, although it has good role in psychiatry, because in psychiatry assessments are more often research, biological data or the biomarkers. So this is the increasing levels of strength in the evidence we will generate, and we we talk about in my experience of treating patients, a lot of case illustrations which as a evidence. Case series, a group of similar patients which have been treated that it has to be in conjunction with the usual treatments, at least in modern medicine. A given condition, for example, major depression here, that would make data, like I said, instead of taking from a healthy subjects group, you go on to a clinic-based sample, and even better, hospital-based sample. Clinic-based are usually outpatients, may not be considered as serious enough, whereas in the group which may reach hospitals, even inpatient, demonstrating clinical effects in this group would have a better strength. Many media, visual media, a lot of suggestive and such suggestive components are best avoided, and not saying ability of the yoga practice is a repeatability. study, it is difficult to group study. You can't attribute the improvement to an intervention. And there could be many other have faith, but that alone should not be the issue where but in research, these subjective elements, people recommend that they are set aside. There could be a compared group. Is it possible? We would say that fellow would have improved even without intervention. Establishing a, I'm not saying cause-effect relationship to an extent that the treatment actually mattered. There was a study that was done earlier in humans, wherein it was a single group study about close to 45 patients were consecutively received yoga at the end of 3 months. 37 people were available for follow-up. So when you looked at these 37 people, not remit. The persons practiced yoga irregularly, and this was significant, indicating indirectly that practicing regular yoga mattered in terms of inducing remission. So you could infer post hoc, post hoc that the treatment, that is yoga or any other Ayush treatment, is the one which brought out. Although this is a very circuitous logic, we need to have a comparison group. Um, Even more recently, too, studies have come with open trial, non-randomized people advertising. These in researchers advertising that this study is on and you could come and enroll yourself, and you examine them at the end of the data pre and post, and yoga is better than doing nothing at all, waiting. uh, Random allocation has been a challenge in many researchers in yoga as well. Even we did a study where in patients who came to the outpatient clinic were all offered yoga, and some did, of course, receive yoga, but most set is to receive a modern treatment and go away rather than spend time coming every day for yoga, etc. This is a non-randomized study, but yet you can see that yoga produced substantial benefits. Uh, the ones who received medicine were not getting as well uh, from the graph, but I don't want it to be interpreted that yoga alone was the best treatment. No, it is not the way to be interpreted. It's possible that those who are coming to the hospital repeatedly were the ones who were tested at the end of 3 months. Those who weren't getting better were perhaps coming for purposes of medicine, which is given in the hospital. So there are many ways of looking at the evidence that whether yoga is better than other treatment. Non-randomized clinical trials, this can be a serious challenge. Randomization is very important in terms of clinical research. The researcher should have both the patient and the researcher should have an element of chance in terms of allocating the individual to true treatment and a comparative treatment arm. Else, the bias of the patient and the bias of the doctor could operate in bringing out results which could perhaps be erroneous. In yoga, there have been challenges. They when they offer when yoga is a research question, they may say, why don't we just give me yoga? Why bother to test it? After all, it is a treatment that has been there for years. Why are you wanting to test this? This is a common question that I have seen. In fact, in one of the studies wherein we did a depression randomized clinical study, although we wanted to randomize, and soon we realized most people, when we offered yoga, they said, you give a yoga, it's a tested one, been there for millennia. Why do you want to do research? Else, forget it. If you want to do the research, that means you don't have any faith in yoga. So all such arguments used to crop up. Patients preferring a given treatment is another challenge, particularly in modern hospitals, to do yoga research. The dropouts become more. They when we randomize and then they ask them to come every day, then there is going to be a difficulty. They drop out, and the numbers of dropout become so huge that the credentials of the research come down. They waitlisting. When you randomize, let's say another group is going to be waitlisted or given treatment as usual, there are some people who feel yoga being an effective treatment, denying it to another group, how ethical it is. Although we would have gone through the ethics committee and so on and so forth, yeah, it's going to be difficult. Waitlisting at least says that, okay, you're going to be given treatment, better late than never. If yoga is beneficial, I'm going to add to you at the end of the trial. What if the trial ends up that the waitlisted group also gets better? So these are all the difficulties in terms of randomization of in yoga research in particular. Comparative trials having a comparative arm. Yoga single arm is out, 2 arms, 3 arms. You need to have a placebo, an intervention which doesn't work, an intervention which is known to work, an active control. Some recommend also have to be there. So an ideal study would be 3 arms, tested arm, that is the yoga, no treatment arm, that is the placebo, and then a known treatment arm, that is the medicine or any other which had been proven to be efficacious. So this is going to be a very difficult challenge that we have faced in terms of comparative studies. So we need to have a placebo. We need to have all elements which resembles yoga. In drug treatment, it is easy. Identical looking capsule. Capsule A, which is the tested drug, and capsule B, which is a placebo, which may contain just some inert material. But that is not going to happen. You're going to conceal everything, and you're going to make all elements of yoga, the movements, breathing, etc., but it should not be efficacious. Or give yoga practices which are not efficacious in this condition. So this is a serious challenge, developing a yoga placebo for the yoga interventions. Yoga is a lifestyle, not just asanas, and so there could be many other things that could happen. And typical yoga teachers say that the yama, the niyama, and so on and so forth have to be added. What are all the components that have to be commonly accepted to be added? The other subjective elements, preachings, rituals can have many other concerns. Particularly yoga, when it comes from important schools of thought, the influence of that guru or the head of the school can also have a faith effect, which will bring about. If I say that I'm doing yoga from this category or this school, I'm sure that will have a different impact on some individuals, not on all, than when I say that yoga is from another school of thought. So this is another concern in terms of comparative study. Placebo is, of course, a serious challenge, and we really don't know how to have an ineffective yoga asana. People say all yoga practices could be having some effect or other. So this concept of placebo in yoga has been a challenge, And we need to have alternatives, like I said, exercise, weightlifting, or removing what we may consider as an important ingredient of the therapeutic process away in the uh, overall module of yoga. Here was a study that was done at Nimmans where the Sudarshana Kriya Yoga, which had Vastrika, Pranayama, and so on and so forth, various processes, including the cyclical breathing, the Kriya. The argument was that had the most significant impact. The other ones were rather preparatory. And so a study was done eliminating the Kriya but retaining the other components. During the Kriya period, a person was asked to sit and breathe normally. And as you can see, group A, full Kriya, group B, partial Kriya. In full Kriya, 75% got better, whereas in the partial, only 50% got better. So, although this was not significant, a trend suggested that a given component had a therapeutic impact. But this has its own limitations of making comparative trials. There was another study that was an interesting study that was done. This is a elderly groups, persons who are participating in a rehabilitation center for early dementia or dementias or memory symptoms, where multiple inputs were given to them. And yoga, wellness, education, group meetings, and so on and so forth. So when this was going on, in randomly, one of them was eliminated in some of these things, and they wanted to see what was the impact of eliminating each of these items. And then they found that on the cognitive and the memory symptoms part of it, when it was rated, the stopping of yoga produced steeper um, disadvantage. That is, one of the elements removed, and stopping of yoga in particular caused the steepest of the disadvantage. The red one indicates that although all of them had some benefit, yoga had the best benefit when it was introduced, and it was withdrawn. Yoga had the yoga group, yoga withdrawn people experienced the worst deterioration. So indirectly demonstrating that yoga was the one which was actually contributing some benefits in this individual. Uh, you could also talk about the dose of yoga. I did mention about regular and irregular in the earlier slide. And here we have an interesting study where yoga was practiced thrice a week versus twice a week. So in a temporal frame, one group would have received 1/3 less of yoga. And then they found that steepness with which the symptoms dropped were better in those who received thrice a week yoga, which is on the left side. On the right side, twice a week yoga, where the steepness of yoga cumulative numbers was also less. Likewise, the steepness with which the symptoms dropped also was less. In fact, those who received twice yoga were having 20% less benefits than those who received thrice yoga. So indicating again a dose dependent effect relating to yoga, meaning that yoga was the one actually causing the benefit. These are all different types of evidence creation that yoga actually has impacted the clinical condition for which a person was treated. Here, of course, we had done a similar work with ECT. I just remembered, I thought I'll mention it in this group here. So we have waitlisting as the control in most of these studies as a placebo. So whitelisted, you're going to get it, you're going to get yoga now. But here, the problem of blinding comes in. A person is not blinded, whereas in the other group, the patient knows what it is happening, whereas the person who is interviewing the patient could perhaps be blind, although we know inadvertently the patients may leak out that they received yoga or they did not receive yoga. Like you may randomize this group, give them yoga in one group, wait for another group, not to get anything. At the end of 2 weeks, you receive this or 3 weeks of intervention. But then there can be, of course, other complications. For example, in this group of alcohol detoxification inpatients with alcohol detoxification program, obviously were quite moderately or even severely ill, and they received yoga, which is the Sudarshana Kriya yoga in this treatment, or no yoga, and they were examined at the end of 2 weeks of treatment post. Of course, over time, many improvements will happen in these acute people, but yet, the reduction was clinically significant, statistically significant. It was better in the group which received yoga in addition to other treatment that this person received for alcohol detoxification. Nonetheless, the magnitude was significant, but this can happen in acute conditions where rapid changes of improvement can happen because of other inputs that the patient has received. And it's possible that the yoga effects can get masked unless you carefully examine this group. Here, of course, we were able to demonstrate a difference. There are, of course, people say something else that is perhaps clinically going to work should also be used as an active control. When you are using an active control, both groups experience benefit, and whether yoga actually is as good or better is another issue which we can look at. And many non-specific elements of movements, physical activity, etc., also can be controlled by way of another active ingredient that has been put into as a control group. This, of course, was a totally an active group where either they received ECT in one group or medicines in another group. Inpatients with the depression were having melancholia were given one of the three, yoga, Sudarshan Kriya alone. Mind you, this was done and published way back 25 years ago. But today, it may be very difficult for inpatients to withhold all medicines and then give only a treatment which is being tested, withholding all other known effective treatments. But not as steep as that had happened with electroconvulsive therapy. But even as a monotherapy, mono introduction, when compared to other active ingredient medicines, the reduction in depression scores with yoga was significant and substantial. So this is possible, demonstrate in active control comparisons, and for various reasons, blinding has been a difficult issue. So people use exercise as a control where the person will believe something is happening physically to him, like just as much as the yoga person is also having some physical activity, and match it with the duration of exposure, contact with the therapist, and the same person giving both yoga for some people, exercise for another group of people. The physical components of physical stress are also matched, and it's possible that the patients can remain double blind. In other words, patients also will not know what treatment I got. Maybe the exercise also may believe that it is going to be yoga itself, but we know that today it is not going to happen. People know what is yoga and what is exercise, the difference. They have seen it on videos and so on and so forth. And here was a group of outpatients who received either yoga or physical exercise or weightlifting. And good number of people got better once something was introduced compared to just weightlifting. Over the course of 3 months, some patients, very small number in the group which was whitelisted, were found to have got some benefit or whatever may be the observational bias. But those who received physical exercise had a better numbers of people who reported improvement were better, and even better when yoga was the one that was given to these individuals. The blue bar represents yoga, the next red one represents the exercise, and the green one represents weightlifting. So it is possible to demonstrate as another control exercise, yoga is beneficial in some of the conditions where it is applied in a randomized clinical trial 4 months after the treatment of yoga. This has been published, and in fact, this publication actually influenced the uh, schizophrenia treatment guideline by an international agency to add yoga or recommend yoga as an add-on treatment in schizophrenia. Example here is people who are contributed to that research. Fact is, multicentric trials, which is one of the stronger evidence building exercise, is possible with yoga research as well. Many people conduct this research in their own centers with similar interventions, yoga, and maybe compare it with no treatment or with relaxation or with exercise. When you do so, replicated data, multiple authors, multiple research groups having done independent study at different points of time in the last 5, 10, 20 years. If you can collate and look at the data, improvements are about the same and significant, and you could calculate a difference using a different statistic, the strength of this benefit. Meta-analysis is the procedure that people apply, and evidence brought out in meta-analysis from randomized multicenter trials is something that is considered as the strongest evidence today with respect to a given treatment to be used on a given population. And it is possible, of course, meta-analysis have been done in many interventions, in Ayush interventions, also yoga and its intervention in many conditions have been examined in meta-analysis, and yoga proving to be beneficial. The benefits are in favor of practicing yoga or prescribing yoga to that given condition. And of course, lastly, I will refer to what is called as the biomarkers as an evidence. These are objective. They have no expectation bias. They happen automatically. The control can be less. Although some people say the placebo also can show some biological effects. But however, if yoga produces biological effects and no yoga produces no biological effects, and we believe that yoga has had an influence on this condition as well, not just only on biomarkers. Biomarkers which may be very therapeutically relevant and the disease relevant are, of course, beginning to be searched and are possible to demonstrate using those biomarkers which are disease specific as well. Of course, else we would be calling them as mere epiphenomena. And the relationship of a change in a biological marker to the therapeutic benefits that the intervention has produced actually adds to the entire strength of the exercise and demonstrating very strong evidence for yoga. Let me illustrate some examples in the biomarker research from our group. Many other people also have done this sort of a research examining biomarkers in yoga. P300 event-related potential is an electrophysiological measure of cognition, which is lower in depression whether it's dysthymia, which is a chronic mild depression, or melancholia, which is a more acute depression, uh, compared to healthy subjects. All the red bars relate to the baseline examination in dysthymia, melancholia. In both, they were about half of that what you saw in what you will be seeing in healthy subjects. You introduce yoga as a monotherapy, Sudarshana Kriya, in this group. Uh, it started to get better. At the end of 1 month, there was a substantial increase in the amplitude of the P300 event-related potential from 8 microvolts to 10 microvolts, or 7 microvolts in melancholia to 10 microvolts. And then at the end of the 3 months of follow-up, the values had almost reached that of the healthy subjects, indicating that normalization of a given physiological deficit seen in ill individuals would happen by way of a given introduction, Ayush introduction, Sudarshan Kriya, or the yoga as an intervention in this study. There are, of course, many other physiological markers which have been more recently studied. One of the physiological markers looks at the role of a neurotransmitter's function in the brain, what is called as the gamma aminobutyric acid function, which is a inhibitory neurohormone, neurotransmitter in the brain. And we can measure that by way of what is called as the cortical silent period. I'm not going into the testing of how you get that. As you can see in healthy subjects, pre and post yoga, this inhibitory effect on this neurotransmitter, by this neurotransmitter on the what is called as cortical silent period was better. Longer cortical silent period was demonstrated after yoga. And we were able to do this in depression. For example, depressed subjects, you can see the healthy subjects, which is a dark yellow bar, was much higher than depressed subjects, the bluish green one, and the first graph, first part of the graph. So depressed subjects have a shorter cortical silent period than healthy subjects. You allocate them into yoga or walking, and in both the groups, patients get some clinical benefit, but in groups of people who received yoga, uh, post-treatment, the cortical silent period had gotten significantly longer, inching towards the healthy subjects' values. The last purple values are the ones of the depressed subjects who received yoga as a treatment, but the measurement was done pre-post in a very short period, less than 1 week, and yet the improvement had already started to happen. And in fact, the subjects also obtained clinical improvement, and the yoga group getting better than that of the walking group. The improvement in subjective well-being was better in the yoga group. So a biological marker improves, or in quotes, becomes towards the normal. Likewise, the clinical signs also get better in terms of they producing improvement. Another biological marker could be demonstrated. Physiology, then we go into some of the biochemical markers. Cortisol, we know that cortisol as a stress hormone gets lower following yoga. A lot of healthy subject studies have happened. In depressed people, because of that stress, cortisol levels are very high, and the cortisol levels have to come down. A biological correction has to happen. And you treat them with antidepressant drugs. Not all will get this correction. Although, again, I don't want you to do a comparative evaluation of these three graphs. This was not a percent, 65% of the people, the patients actually lost cortisol. Again, a caution should not be seen as a comparative study, because this data is from a study which was not a comparison, not a randomized comparison. But suffice to say, yoga introduction improves depression, at the same time do a biological correction in making people lose cortisol. More people lost cortisol. 65% of them lost cortisol, which is an indicator that the stress levels having had come down in this group of people, in addition to their depression having gotten better. A biological correction happened, and this correction was related. This is a graph generated from a group of people who received only yoga. In this group, we found that the degree to which the yoga produced clinical improvement. So losing cortisol, losing depressive symptoms correlated in these people who received yoga as the only treatment, but having a clinical diagnosis of depression. So yoga benefits clinically, also corrects biologically the basis. Yoga effects on the brain are another area where people have examined. I talked about physiology, I talked about biochemistry. Now we're talking of structural and neurophysiological benefits which can be demonstrated. Here is a group of elderly subjects. This was a pre-post analysis. Again, its limitations I have already mentioned. 7 subjects who had yoga. 6 months later, the hippocampus was measured. The arrow points out to a white spot wherein the values of the gray matter having increased fast pace. And even more so when people start to have memory symptoms, which is a forerunner of dementia. This is the first one that could be happening. Many of us, at the end of this 1 hour, elderly persons would have had 1 or 2 neurons having been lost. Although I'm mentioning it in a very lighter vein, please note that the speed at which hippocampus shrinks is much faster. It is the first one to start shrinking. Introduced yoga at the end of 6 months. Actually, the gray matter volume actually had gotten better in this. So yoga had protected, in a way, the neurosenescence. This is another demonstration. Of course, we would have had this evidence much stronger in terms of demonstration had we used a control group, and we did not use it. So the study, but neurophysiological biomarker to a neurostructural biomarker is possible. And lastly, amongst the biomarker data, I want to introduce more recent ones, what we call as live functional magnetic resonance imaging. Actual areas of the brain which are working and are getting changed by yoga practice is actually demonstrable. This is what is called as the defense mode network. Gone are the days when we talked about some regions of the brain are the ones that are happening, but the interconnections in that region is even more important. Not just the volume, not just the shape of that organ, but the connections in those areas. And this network in each of the area and its coherence can be today measured thanks to the technology of the functional magnetic resonance imaging. As you can see here, this is an example of a schizophrenia individual pre to post. 3 months later, the network had become more active. The yellowish color indicates statistically this area, the coherence of the networks was better. The default mode network, both anterior and posterior, went on to get much better with the practice of yoga. And in this group of people, the negative symptoms of schizophrenia actually improved. The improvement happened. Of course, this is a randomized controlled trial. The graph shown is, of course, the image shown is of a typical patient as an example. But if you pull the data and look at the influence of yoga, yoga gets their negative symptoms better, and the reduction of negative symptoms was associated or correlated with the coherence in the default mode network. Both were demonstrable. Again, another biological marker which had a bearing or a relationship with the therapeutic influence of a given treatment, Ayush treatment, yoga in this example. So there are many other challenges. I already talked about blinding. How do you blind the patient and the therapist in terms of what he is getting or she is getting, and the influence of different schools of yoga? Should we move away from the schools of yoga description to a generic yoga modules which have to be tested? Is a question that we have already written a paper on this agenda. Where do you do this study? People who gravitate to an allopathy center, their expectation would be not yoga but something else. Thanks to the Ayush department and the health departments of both center and state, co-localization of Ayush treatments in modern hospitals and vice versa has made this task a lot easier. That we have to encourage it to get better. There are subjective measures, particularly in psychiatry, and when you do other research on pain and things like that, again, subjective measures become very important, and they are difficult to corroborate by objective evidence. Concurrent treatments, when you give, they may produce so much of improvement, and so you could mask the benefits of additional improvement with yoga. So concurrent treatment should be given or it should be monotherapy is another issue that we need to have some difficulties to overcome. And of course, in mental health practice, practicing yoga is another challenge, because typical yoga gurus say that this person's mind should be quieter when he is calm, should be at peace when he is practicing yoga to get its best effects. And we know in psychiatric patients, the motivation, being mindful on the yoga practice can be compromised. And this is something that we have to keep focusing when we are introducing a given treatment, yoga in particular. It, of course, mental state has, of course, is a barrier. Another treatment compliance, adherence to treatment, and so on and so forth. But that is another issue which we need to factor when we are generating evidence. Whether yoga in general would mean what? A given capsule of yoga having a given yogasanas, given pranayamas, unique to a given disorder. Is it possible? Today we have had groups developing yoga modules for given conditions, whether psychiatric conditions or non-psychiatric conditions as well. Some set of yoga practices produce perhaps the best benefit than other practices. And in fact, some other practices should not even be given in these groups because of some other side effect reasons. So put together, we have to develop yoga modules which are generic, which are, of course, going to match a given disorder. And how do we do that? Look through the scriptures, look through the traditional texts, and see what are the benefits of given practice A, B, C, D, and then relate it to the symptoms of a given individual. This exercise is a huge exercise. I'm sure all of us will be willing to do that. So once a capsule is made, how we all agree that this is the standard one that should be used in a given condition X. Mind you that yoga books were not written for purposes of treating a given condition. It was supposed to be a spiritual lifestyle that was something that we have to inculcate. Very often mentioning about side effects in court of a given intervention, Ayush intervention, is not often made, yoga in particular. So this is some effort that I think we should consciously make if our evidence has to be demonstrated very, very strongly. And contraindications also we probably have to write, not just indication as a disease, but in the disease, when should the intervention happen, when it should not happen. indications and contraindications also have to be developed in terms of practice with the knowledge that the evidence-based research is producing. And of course, lastly, dosing of a given Ayush intervention yoga in particular, like I said, twice a week, thrice a week, half an hour a day, daily. Some have to be, each posture had to be held for half a minute, 20 seconds. So these are all the issues. How much we can refine, define, agree to consensus is another area I think we need to keep in mind. But take home message is building evidence, base in an Ayush intervention, yoga in particular, is possible with sustained efforts in research. And I'm appealing to all the researchers to pursue this task of building as much evidence as possible in Ayush interventions. And I devotefully offer pranams to Mata Saraswati for giving me all this wisdom to be able to share with you. And most of the work that was presented here was the work that had happened and is continuing to happen in the Department of Integrative Medicine, then called the Yoga Center at NIMHANS. The work happened there. I thank all my colleagues who helped me in formulating this presentation for this meeting. And any of the persons could write to me. I thank all of you. My email is here. Any questions to be asked, I'll be happy to send back the answers on their own mails. I once again thank the Bhopal AIMS group for having called me to this presentation. Dhanyawada.
Thank you, sir. So thank you so much.